Welcome to the Bureau of Community and Health Systems video training on end-of-life care for caregivers in long-term care settings. The dying process usually begins well before death takes place. Being tuned into the physical, mental, and emotional changes can help you recognize the signs of dying and assist the resident and family in the process. In this training, we will cover the end-of-life stages, understanding mental and behavioral changes, understanding end-of-life emotions, understanding hospice, and support for residents' loved ones. Let's learn together.
The Palliative Performance Scale is a tool that some medical staff use to measure a patient's functional decline and predict survival for patients with serious illnesses. The scale assesses 5 functional dimensions: ambulation, activity level, and evidence of disease, self-care, oral intake, and level of consciousness. Clinicians sometimes use the Palliative Performance Scale to assess a patient's functional status to make informed decisions about their hospice eligibility. As a caregiver, there is a chance you will play a large role in caring for a resident who is on hospice or who is nearing the end stages of their life. Identifying stages as a resident transitions is important for the resident, their loved ones, and their caregivers to discuss. The resident's assessment plan should be updated as the resident transitions and care needs change. Upon the resident's request, document his or her final wishes. Residents and their loved ones can work together to discuss a resident's final wishes. Each person is different as the body goes through a natural dying process, including a decline in cognition, circulation, respiratory, and muscle atrophy. End-of-life signs can vary from person to person. However, the more clinical signs a resident exhibits signal the end of life's journey. On the screen is a broad timeline of end-of-life stages for 1 to 3 months before a resident's passing. Under each symptom are helpful tips to assist the resident and family. Decreased appetite. Offer smaller and more frequent meals. Provide highly nutritious foods. Discuss food choices and offer favorites. Increased pain and nausea. Per their doctor's orders, adjust pain medications as needed. Use prescribed anti-nausea medications and provide comfort. Increased tiredness and sleeping. Ensure a comfortable sleeping area and allow for rest and sleep. Offer relaxation techniques. A higher risk of infection. Maintain good hygiene, monitor signs of infection, and educate residents' loved ones on what to look for. Increased agitation. Respect alone time, support and reassure the resident, and encourage open communication. Weight loss. Verify any contributors to weight loss and monitor resident for skin breakdown and sores. Weeks leading up to a resident's passing, the resident may show various symptoms. There are several ways in which caregivers can help residents feel more comfortable during this transition. Residents may feel an increased need to sleep. Caregivers should allow residents to rest, create a comfortable sleeping area, and educate their loved ones about sleeping changes. Residents may have no desire to eat. Caregivers should monitor for signs of distress or discomfort. Respect the resident's decision to eat or not to eat, and offer sips of fluids to prevent dehydration. Caregivers should provide mouth care to avoid dry mouth and report the resident's refusal to eat to the resident's doctor. The resident may experience increased agitation. Caregivers should respect the resident's alone time and support and reassure the resident. The resident may be restless. Caregivers should check for causes of restlessness, reposition the resident for comfort, and offer relaxation and calming techniques. Caregivers should check for increased congestion and elevate the resident's head for ease of breathing or use a humidifier. A resident may experience increased confusion. Caregivers should provide clear, simple explanations and use visual aids if needed. Caregivers should ensure a calm and quiet environment. A resident may experience hallucinations or visions. Caregivers should reassure, support, and validate the resident's experience. The resident may experience changes in vital signs. Caregivers should focus on the resident's overall well-being and educate the resident's loved ones. 4 to 6 days before a resident's passing, residents may feel intensifying emotional and physical symptoms and abnormal vitals. Caregivers should educate the resident's loved ones, and only per the resident's doctor's orders. Discontinue the resident's blood pressure medications. Residents may feel a decreased level of consciousness. Caregivers should educate the resident's loved ones and ensure the resident is comfortable. The resident may experience dysphagia of liquids, making swallowing difficult. Again, it is important that caregivers are educating the resident's loved ones. Caregivers should provide ways to keep the resident's mouth moist and provide hydration alternatives. As the end approaches, 2 to 3 days before a resident passes, the active stage of dying begins. Common symptoms include unresponsiveness and a significant drop in blood pressure. Residents could experience peripheral cyanosis, a condition that causes the skin on the hands, fingers, toes, or nose to appear bluish or dusky in color. Educate the resident's loved ones on this condition and keep the resident comfortable and warm. Monitor closely for changes in color. The resident may experience a decreased response to visual stimuli, so it is important to maintain a calm and soothing environment. You might notice a resident's breathing pattern is characterized by alternating periods of deep, heavy breathing, shallow breathing, and apnea or no breathing. This is called Cheyne-Stokes breathing. Educate the resident's loved ones about Cheyne-Stokes breathing and its normal occurrence at end of life. A resident's doctor may consider opioid use for managing this condition. Approximately 2 to 3 days before a resident's passing, their pupils may become fixed and dilated or unresponsive and staring. Ensure the resident's comfort and provide emotional support to their loved ones. In the final hours, residents exhibit specific clinical signs that indicate the approach of death. A common symptom of the dying process that occurs is when a person's upper airway fills with secretions, such as mucus and saliva. It creates a gurgling or wet rattling sound that occurs when the person breathes in and out. It can also sound like a soft moaning or loud snoring. This is called a death rattle. It is important for the resident's loved ones to understand that the death rattle usually doesn't cause pain or discomfort for the dying person. Caregivers can work with hospice staff to reposition the resident to promote drainage. In the final hours leading up to a resident's passing, you may notice a decrease in the resident's urine output and a pulselessness of their radial artery. The resident may also lose their ability to close their eyelids. Use a wet washcloth if the resident's eyes are dry or irritated. Caregivers may notice a resident is experiencing grunting of their vocal cords. Educate the resident's loved ones about the possibility of vocal cord tension. Hospice clinical staff may prescribe medication if pain is present. Administer medication to the resident as prescribed. Residents may have a fever. Place a cool washcloth on the resident's forehead, remove excess blankets, and use a fan. Administer the resident acetaminophen if necessary and as prescribed. Mahatma Gandhi said, "There are no goodbyes for us. Wherever you are, you will always be in my heart." Let's move on to understanding the mental and behavioral changes a resident goes through towards the end of their life. Social and cultural factors help shape a person's dying experience. For example, research suggests males are less likely to talk openly about their mortality and end-of-life wishes. One study suggested that males tend to delay talking about death and want to discuss hard facts rather than feelings. Females lean toward soft facts, but also find talking about death challenging, even though they seek to find more information. Religious and cultural backgrounds can influence how someone feels about dying. Personal reflection becomes important. The dying person often thinks back over their life and revisits old memories. They might also reflect over the things they regret. Withdrawal is common as they start to realize death is approaching. They are beginning the process of separating from the world and the people in it. During the early stage, it is not uncommon for a resident to say no to visits from friends, neighbors, and even family. When they do accept visitors, it might be hard for them to interact. That may make loved ones feel rejected. Clinical indicators and symptoms are not the only signs of a resident's impending passing. Analyzing emotional signs can also shed light on a resident's end-of-life status. Some of these signs include a prolonged state of excessive fatigue, sleep, appearing catatonic, confusion and/or disorientation, hearing or seeing people and events not visible or not present to caregivers. The resident may display social withdrawal and detachment, or the desire to conduct a life review, settle something unresolved, or focus on funeral planning. We mentioned hospice several times in this presentation. Let's discuss hospice in more detail. Hospice supports people near the end of life. Hospice agencies can provide care in an individual's home, in an adult foster care facility, a home for the aged, a nursing home, a rehabilitation facility, a hospital, or at hospice centers. Hospice care aims to improve the quality of life of the resident by focusing on their comfort and peace and not on the cure of their illness or disease. When a resident begins hospice care, medication and other treatments to cure or control their serious illness will stop. For example, if they are receiving chemotherapy that will end before they can enter hospice care. However, a resident in hospice can continue to take medications to treat other conditions or symptoms, for example, high blood pressure medication. Hospice care is typically available to residents with a life expectancy of 6 months or less. Hospice care provides compassionate care for residents in the last phases of incurable illness or disease and/or simply aging, so that residents may live as fully and as comfortably as possible. The hospice philosophy accepts death as the final stage of life. It affirms life but does not try to hasten or postpone death. While some may think hospice provides care to residents 24 hours a day, 7 days a week, this is rarely the case. Subsequently, if you care for a resident in a long-term care setting who is on hospice services, it is imperative that you be trained on end-of-life care, so that you can provide proper care to the resident when hospice is not available. A person from a hospice care team should always be available by phone 24 hours a day. It is also extremely important to understand the administrative licensing rules regarding do not resuscitate orders in long-term care settings. For example, under no circumstance can an adult foster care licensee honor a do not resuscitate order or no code request for an adult foster care resident. If a resident enrolled in a licensed hospice program with a do not resuscitate order in his or her hospice service plan suffers a serious adverse change in his or her medical condition, the adult foster care facility is to immediately contact the resident's licensed hospice service provider instead of emergency medical services. The licensed hospice service provider will determine the appropriate course of action. If the same resident is involved in an accident and needs emergency medical care, the adult foster care licensee or their staff is to contact emergency medical services immediately, followed by a phone call to the licensed hospice program. Providing comfort during difficult end-of-life experiences is essential. A resident's loved ones need time to process their feelings after a resident passes away. They should not be subjected to additional stress. Be empathetic. The time, setting, and specific events surrounding a loved one's death shape lasting memories for their loved ones. To support residents' loved ones as they begin the grieving process, give them private time alone with their loved one after a death to say their goodbyes and share memories. Answer their questions factually, calmly, and with empathy, and explain clearly and compassionately what will happen in the next several hours or days. Honor loved ones' needs for specific rituals at the time of or shortly after a resident's passing, such as bathing of the body, recitation of prayers, or dressing of their loved one in special clothing or garments. Make sure the immediate environment is as uncluttered, clean, and orderly as possible, with no offensive odors. Encourage a healthy grieving process. Remind loved ones and fellow caregivers that each person's grief is unique and will ebb and flow over the following days, weeks, months, and years. If the resident was on hospice care, Medicare-certified hospices provide up to a year of grief and loss counseling for the resident's loved ones following the resident's passing. The great poet Thomas Campbell wrote, "To live in hearts we leave behind is not to die." The job of a caregiver in a long-term care setting is often thankless, but their role is vital in preserving a resident's dignity, especially towards the end of their life. Caregivers are often characterized as caring, attentive, communicative, tough, stable, patient, understanding, kind, empathetic, and compassionate. Thank you for all you do to keep vulnerable residents safe. Thank you for learning with us today.